Okay, so a diverticular abscess and septic shock. So, 76-year-old lady critically ill with long-standing constipation came to A&E with left leg fossa pain. On examination, her BP is 90/60, heart rate 115, temperature is 39, respiratory rate 27, with the blood and pH is 7.3, acidosis, partial pressure of 40 is 9 Pascal, CO2 is 2.5, and HCO3 16, basic says WBC 17,000. So here is respiratory compensation and then is metabolic acidosis with unstable vitals, critical derivation, long-standing constipation, and right fossa pain. Is the surgical ST3 on call? You are asked to see an 85-year-old lady in the emergency department who is complaining of left fossa pain. She has not opened her bowels for 7 days. This is unusual for her. She has a past medical history of osteoarthritis, hypertension, diverticulosis, and hypothyroidism. She has no allergies and taking codamol 15 by 500 milligram, 2 tablets QID, TDS, amlodipine 10 milligram OD, and levothyroxine 125 microgram OD. Her observations are 120 heart rate, BP 110/90, saturation 98% on rate, room air, and the temperature is 38.3. So what are your differentials? So my differential are diverticulitis, sigmoid volvulus gastroenteritis, acute constipation, and biliary tumor, and can be uretary colic. Interpret ABG full blood count. So this is metabolic acidosis with partial compensation. Partial compensation because pH is abnormal still. If pH is normal, then we will see full compensation. Increased total leukocyte count in WBC in the blood picture. Full blood count. What is shock? Shock is a systemic state of low tissue perfusion that is inadequate for normal cellular respiration. Or shock is circulatory failure resulting in inadequate organ perfusion such that cannot meet the metabolic demands of the body or the tissues. What are the types of shock? Shock can be a polemic shock, for example, hemorrhage shock, trauma, surgery, non-hemorrhagic shock, burn, pancreatitis, diarrhea, vomiting, evaporation to or third spacing, for example, leakage of fluid from the vessels into the third interstitial space. Cardiogenic shock, MI, cardiac dysrhythmias, heart failure, valvular heart disease, blunt myocardial injury, cardiomyopathy. Obstructive shock, cardiotympanoid tension, pneumothorax, pulmonary embolism, distributed shock, neurogenic shock, septic shock, anaphylactic shock, endocrine shock, Edison crisis, exedema, coma, and thyrotoxic crisis. What type of shock is this patient having? Septic shock. Define septic shock. So this is the presence of sepsis associated with hypotension, systolic blood pressure less than 90, or hypoperfusion resulting in an organ dysfunction despite adequate fluid resuscitation or the requirement of inotropes such that persisting lactic acidosis, decreased urine output, and altered GCS. So again, what is septic shock? So you know that sepsis is equal to documented infection plus SIRS, systemic inflammatory response syndrome, or suspected infection plus equal to or greater than 2 Q SOFA. So what will be septic shock when hypotension come into action? For example, sepsis and hypotension after adequate fluid resuscitation. Sepsis plus vasopressor plus lactate greater than 2. So again, come to the definition. This is the presence of, so septic shock is the presence of sepsis which is associated with hypotension. Presence of sepsis which is associated with hypotension or hypoperfusion resulting in an organ dysfunction despite adequate fluid resuscitation or which requires inotropes. Persisting lactic acidosis, decreased urine output, and altered GCS. Okay, so again, presence of sepsis with hypotension such that systolic BP is less than 90 mm of Hg in spite of adequate fluid resuscitation or inotropic use. So this is sepsis. So sepsis, documented infection plus systemic enteral response syndrome, or suspected infection plus greater than or equal to 2 Q SOFA. Sepsis plus hypotension after adequate fluid resuscitation, and sepsis plus vasopressor plus lactate greater than 2. Septic shock. Okay. So recognizing septic shock clinically is more complex as it can be assessed only by the response to treatment. Patients who have an infection and persistent hypotension after fluid resuscitation, persistent lactate of more than 2 millimole per liter after resuscitation, or vasopressor requirement to maintain a mean arterial pressure of greater than 65 mm of Hg in the absence of hypovolemia are all considered to have septic shock. Septic shock is associated with a 40% mortality rate. Parameter used in SOFA, sequential organ failure assessment, or sequential sepsis related organ failure assessment score. SOFA score. So this is different than Q SOFA. So SOFA score is respiration, coagulation, platelet count, and circulatory. We check mean arterial pressure, liver bilirubin. So these are the parameters: respiration, partial pressure of O2 divided by function fractional inspiratory O2, FiO2, partial pressure of O2 divided by FiO2, Carico index. So this is respiration, coagulation, platelet count, circulatory mean arterial pressure should be greater than 65 mm Hg, liver bilirubin, CNS, GCS, and direct and urine output. And what is Q SOFA? 2 or more of the following: systemic blood pressure less than 100, respiratory rate greater than 22, or GCS less than 15. So 2 or more of them. GCS less than 15, respiratory rate greater than 22 mm per minute, systemic blood pressure less than 100 mm of Eg. And SIRS 2 or more of the following: temperature less than 36 or greater than 38. This was the old criteria. This is the old criteria. This SIRS, this one, and this is the new criteria. So in SIRS we look for 2 or more: temperature less than 36 or greater than 38, respiratory greater than 20, heart rate greater than 90, and WBC less than 4000 or greater than 12,000. Whereas in Q SOFA, systemic blood pressure should be less than 100, respiratory greater than 22, and GCS less than 15, 2 or more of them. How will you manage? Okay, how will you manage this patient? Basic principle of management of septic shock. Surviving sepsis campaign has recommended the concept of care bundles, which include 2 recommended management packages or care bundles: the 3-hour care bundle and the 6-hour care bundle. So sepsis 6, take 3, give 3. So blood cultures before 1 dose of antimicrobials, blood tests including lactates, and urine output as part of the perfusion status assessment. So oxygen, give oxygen, IV fluids, and if deficit, oxygen if required, and IV microbial local guidelines. First hour, sepsis 6 completed: O2 fluids, antimicrobial culture test, urine output, and assess your patient response. Means that in first hour bundle, give these, and then we have to assess the patient. 3-hour bundle, diagnosing and treatment reviewed with blood and other test results. Sepsis and septic shock diagnosed and documented as appropriate. Lactate repeated if first abnormal. Assess need for source control. Assess and the need for source control. Patient care escalated to specialist care as required. 6-hour bundle, patient diagnosis and treatment reviewed. Again, review the patient diagnosis and treatment. Is your patient responding, stabilizing, or deteriorating? Is your patient responding, stabilizing, or deteriorating? Pressures commenced in patient with fluid resistant shock. So these are the 6-hour bundle. First hour bundle, take 3, give 3. Third, review your diagnosis and treatment and blood test. Also check the lactate. If greater, repeat it. Also look for sepsis or septic shock and document it as appropriate. Assess need for source control and patient care should be escalated to specialist care or not. Decide this. Alternatively, organ support. So circulatory to maintain the cardiac index and oxygen delivery to the tissues. Use IV fluids, colloids and crystalloids such as 0.9% solution. Anotropes may be required to increase the systemic vascular resistance. So what is cardiac index? Cardiac index is the cardiac output per meter square area of the body. Okay, so this should not be less than 2.4, and when it is less, so it means that there is sepsis, hypovolemia, dehydration, and if it's greater, I think it's greater than 4. So this shows hyperdynamic condition, for example, hypothyroidism or anemia and cardiac failure or overload. Okay, so respiratory support. So to maintain the circulatory support, we give IV fluids, colloids, crystalloids, size by 9% saline. Inotrops may be required to engage the systemic vascular resistance. For respiratory support, non-invasive or invasive ventilation may be required for the management of ARDS and respiratory failure. Renal support to ensure that the urine output is greater than 0.5 ml per kg per hour. So dopamine or furosemide infusion may be required to support the failing kidney. Cardiac support helps maintain the renal perfusion pressure, and renal replacement therapies may be also be required. For example, dialysis, renal replacement therapies. Nutrition support may be enteral or parenteral. Enteral nutrition helps maintain mucosal integrity and reduce bacterial translocation. So should we consider first enteral, and if non-muscle, you can go for parenteral nutrition. Antimicrobials. During the early phase, there is empirical use of broad-spectrum antibiotics and surveillance of infection, but in the later stages, agents are targeted to clone microbiological sensitivities from general, such as blood and local source. You requested for a CT, abdomen and pelvis, which confirm the presence of a diverticular abscess. What are the management options? What are the advantages and disadvantages of them? My management option can be open surgical or image-guided radiological aspiration. So open surgical advantage: proper drainage with peritoneal toilet has the ability to make a stoma if needed. Disadvantages: liability of wound infection, general increase in morbidity. Yes. Image-guided radiological aspiration. Advantages: no wound infection, less hospital stay, minimal invasive, possibility of leaving pigtail catheter for repeated drainage and administration of antibiotics. Disadvantages: less adequate drainage, does not have the ability to make a stoma, and there can be recurrence of the or persistent abscess. Okay, so this was all about the sepsis and so again, sepsis, recommended infection and SIRS or suspected infection plus greater than or equal to Q SOFA, and septic shock will be sepsis plus hypotension after adequate fluid resuscitation, or sepsis plus vasopressor plus lactate greater than 2, persistent greater than 2.